So another kind of dramatic presentation in the Mount Sinai ER. This was a younger man, 68 years old, with a history of squamous laryngeal cancer that he had had X-ray therapy, chemotherapy. He was tracheostomy and PEG tube dependent, although also living totally independently. When he presented to an outside hospital with bleeding from his trach site. That was apparently rather brisk and alarming at the outside hospital, and they initiated a transfer to Sinai. When he came to Sinai, though, he wasn't bleeding and he was hemodynamically stable. He was extremely tachycardic. He was seen in the ER, and his right neck was completely swollen. He couldn't open his mouth, couldn't move his neck. He was tender, really tender to touch across the whole jawline and upper chest even. It was all indurated and just very, very swollen. His skin was terrible. It was almost orange peel-like in its post-radiation changes. This is actually a look at his neck. You can see he was a stocky guy to begin with, with the radiation changes and the just massive swelling around this neck, there was almost no domain whatsoever there. He had zero range of motion, really. Thoracic surgery actually did a quick bronchoscopy to see if there was a tracheonominal fistula, and he got a CTA as well. On the CTA, there's post-surgical changes everywhere, but the main thing that you should be paying attention to is on the right side here in the carotid sheath. You see this slightly more radiolucent area with some dots of air in it right next to the carotid. And then you get here, and there's really basically an abscess in the carotid sheath. And then a large pseudoaneurysm there as well. My eyes went right immediately to the carotid, but the radiologist saw that there was actually a component of it that was retropharyngeal, kind of in a Ludwig's angina type distribution. There was evidence that there could have been actually tumor recurrence. However, that was very unclear from the scan just because there was so much inflammation from the abscess. The immediate plan was basically to proceed with, by the way, this patient was, looking at this scan, you can tell it's poor prognosis if we had done nothing. The possibility of just, comfort measures and palliative care was discussed. ENT felt that he had a decent prognosis from a cancer perspective if we could get this infection under control. So we ended up proceeding with attempting to bring him for open drainage and reconstruction of the carotid. We knew it was going to be difficult because of his limited range of motion and neck, everything, and his poor skin and everything else. But we still felt that the most long-term solution would be an open reconstruction. However, en route actually to the OR the next morning, the patient started having massive blood loss orally and actually through his trach as well. I'm not sure exactly anatomically how the blood made it into everywhere, but it did. The patient became immediately hypotensive, and we actually didn't even make it down to the intended OR. We diverted to the head and neck ORs, which are in a different building. Then we decided at that point that we should try to do a temporizing type procedure with an endograft, which was no small feat in an ENT room. But we did end up getting halfway decent imaging. This is a run. I have my sheath up in the common carotid artery. You can see that pseudoaneurysm, which looks almost unthreatening in that picture. You don't see a lot of extravasation, just to the pseudo, but he had literally just bled to a life-threatening extent. And basically, I parked, I think you can already see I parked my stiff wire up in there's an Amplatz wire with a short tip in the external carotid artery. And we brought up a 7x59 atrium stent graft. I think you could definitely make the criticism, why did you use a stiff balloon expandable stent in a neck? Well, first off, this patient is completely unable to move that neck. It's rail stiff. And second, that's what we had available, and the patient was bleeding to death. We went ahead and actually deployed the stent graft, and you can see complete resolution of that pseudoaneurysm. After that initial procedure, there's still this contained pus, and the patient was still acting a little bit on the septic side. ENT wanted the external carotid actually embolized before they went in and attempted to, drain that abscess, because they were worried about just the bleeding from the area. We turned it over actually to neuro-IR at this point, who did a external carotid embolization here, and they also did a balloon test occlusion of the internal carotid to see if that could be sacrificed as well, which she passed with flying colors. Basically a couple days later, his white cell scan normalized, and he essentially did well. He lived another 18 months on suppressive antibiotics, but unfortunately, on late follow-up, it turns out that the patient did end up succumbing to a tumor recurrence. So this was really a finger in the dike type case, but I thought it was still worth presenting.